Uh, I thought I would present today the data, obviously, which is new, but my talk is to convince people here that mitral regurgitation is a very serious disease and it kills. And we need to think about technology, and now that we know we have new technology, so we can use it to its advantage. So this is why I'm going to tell you a little bit about the history, why we need to do it, and these are my disclosures. And I'm going to base my talk around these 5 headings. One, the problem. So I'm going to convince you there is a problem. And then we'll go on to the rest, which is types and treatments and technology itself. So looking at the facts and figures, and as you can see from this slide, it is the second most common valvular condition. And in Europe, which obviously maybe in our subcontinent even more, 4 million people suffer from significant mitral regurgitation. We are not talking of mild, moderate, we are talking 3+, 4+. There are nearly 250,000 diagnoses every year of mitral regurgitation, which needs treatment. More than 100,000 mitral valve operations are performed annually, and over the age of 75, 10% of people have clinically relevant MR. So I hope I'm getting my message through that it is a problem. I thought my time was 15 minutes. So it is a progressive disease. It has consequences. It reduces quality of life, leading to, because of left ventricle dysfunction, heart failure, which then translates into increased mortality. And 50% of symptomatic significant MR do not receive any intervention for various reasons. And asymptomatic severe MR has a mortality, 5-year mortality of over 25%. So all of us have to understand that this is a problem, and we need to think about newer treatments available. And if you look at the 2 blue bars, you can see that people over the age of 65, look at the blue bars. That's the incidence, and it goes into 10% of people over the age of 65 or 75 have mitral regurgitation. And we know that if you have heart failure on top of mitral regurgitation, your survival is reduced. If you look at that the graph, if you look at the severe part of it, so your mortality is reduced. And we also know that if you refer people early, it saves lives. And we're talking of transplant-free, but we don't have that service here. But still, the survival is improved the earlier people are referred for treatment. So a brief word about, I'm sure I've convinced people that there is a problem, right? And I can see smile on Nader's face, so I've convinced him. The classification of mitral regurgitation for fellows and colleagues who are interested, there are basically 2 types. The primary MR, which is here, and which is a valve problem. And there's something wrong with the valve or the subvalvular apparatus. And secondary MR, where the ventricle or rarely the atrium is the problem, both leading to dilatation of the annulus and hence mitral regurgitation. The degenerative MR, we agree on this, that 60 to 70% of MR that is referred for treatment is degenerative, and there is absolutely no doubt the gold standard is surgery. But there is a but here, and if you look at this slide, above 70 years old, only few people, 42% got actually treatment. A majority, and above the age of 80, only 15% were referred for treatment because of comorbidities and the age, just being the age being one of the factors. So a lot of people with degenerative MR do not get referred for surgery, which is the gold standard. And what happens to those people? We know that once you are referred, then we want to have repair rather than replacement. And because we know repair is better than replacement. But how many centers do repair? How many surgeons are just interested in repair? Most people would just do mitral valve surgery, but if you look deep into the data, we know that people or centers which do more than 100 procedures, their adverse outcomes are less, as you can see. So the more the procedures, lesser the adverse outcome. So we need a center that does mitral surgery, we need a surgeon that does mitral repair, and we need surgeons to accept people over the age of 70. But that's not happening. A lot of people are denied. So even in degenerative MR, we need a lesser invasive and a safer option, and hence the Mitraclip. In the functional MR, we have two categories, dilated ischemic cardiomyopathy, and more than 50% of patients who have heart failure with severe secondary MR, and in nearly 10 to 15%, it will be severe. And prognosis is poor when you have functional mitral regurgitation. And even if you look at the guidelines for surgery, it's a class 1 indication if you are going for mitral repair plus cabbage. But if you look at the last column, if you are just being referred for mitral repair, it's not a class 1 indication. It's a class 2B indication for surgery. So in the functional MR, we agree again, the problem is not the valve, but it is the ventricle. So we need proper treatment, guideline-directed medical therapy. And that's where Mitraclip came in. For those people with degenerative who were not referred for surgery and for functional MR, that's how Mitraclip came. And I'll just tell you briefly about the technology. It is based on an Alfieri stitch, which is surgical, just stitching the anterior and posterior leaflets, creating 2 lumens, as you can see here. And that's what a clip looks like once it is deployed. And the technology looks a little bit complicated, but it isn't. It's a clip and a grippers. Grippers are on the atrial side. The clip is on the ventricular side. And if you look at the whole, the clip, Mitraclip, and it has basically a guide cath and a clip delivery system. Once you do a few procedures, then you get used to this technology. And how it works, you have different knobs and controls, and you open the clip, close the clip, deploy the grippers, and you're trying to catch the mitral leaflet between the grippers and the clip. Now, the newer 4th generation clip has come up with the better, the longer arms and wider arms, and the G4 system, and there are 2 Pascal system. Edwards have come up with a Pascal system. I've used only one, but you need to get used to it. And this is how the thing works, where you deploy, you open knobs, and this I just wanted to show how the clip works. Your aim is to get the clip open and the leaflets rest on the clip, and then those 2 things up there, these are called grippers. They are deployed, and the clip entraps the mitral leaflets, and then you close the clip, and that's how you create you hold the anterior and posterior. And then you can close it, you can reopen, you can place, and everything can be done. So if you haven't got a good result, you can reopen the clip and invert it. So just a quick word about the evidence. We have a lot of evidence now, and you look at from where we started in 2000 when we came in with the Everest 1 trial, and we've gone through various trials which have then led to some guidelines being changed in 2014. The guidelines included clip as a therapy, and in 2020 there are now newer guidelines even for functional MR. And there are various trials that you can look at, and Everest 1 was done a long time ago in US just to prove it is safe. And then now the most recent trial is COAPT-PAS, which was presented in ESC just a month ago. The Mitra-FR and COAPT created a lot of issues. Actually, I was involved in the Mitra-FR because I was proctoring 27 out of the 37 centers in France. These were published in New England Journal, and you can see that it was 37 centers, but there were a lot of issues. There were people randomized 150 in each arm, and the primary endpoint was death and heart failure hospitalizations. But surprise, we found no difference in the guideline-directed medical therapy plus guideline medical therapy and clip. So this was a big setback for us to people who believed in mitral regurgitation and the percutaneous treatment. But when you look deep into the trial, you saw the problems. And as I said, I was in 25 centers myself, so they were very inexperienced operators. Definition of mitral regurgitation was different. There was no guideline-directed medical therapy. Just before you get up, I thought my time is 15 on the printed list. 15 minutes.
चलें अभी आपको करने दें. Let's.
And then there were some very problems that we saw. Why the Mitraclip came as it is. But then the life-saving COAPT trial was presented. And COAPT was also published in New England Journal with 2 arms with guideline-directed medical therapy plus CRIP and the therapy on its own. And it really showed that there was a difference in mortality, all-cause mortality, 38% relative risk reduction in the 2-arm, which is CLIP versus CLIP and medical therapy, and also reducing heart failure hospitalizations. So the COAPT gave some new energy to us, and we started believing in the CLIP. And now recently, COAPT PAS trial has been, which is an observational study, but it was unlike COAPT patients. These were real-time, contemporary, real-time world settings of people who had a lot of comorbidities with poorer ejection fractions, and the outcomes were all-cause mortality, heart failure, hospitalization, MR severity, and a lot of patients had comorbidities, as you can see here. They were people with chronic lung diseases on oxygen. They were people on inotropes. And look at what the results showed, that the effective mitral regurgitation reduction was seen. I mean, like if you see the first bar, which is nearly 76% of people had severe, in the over 1 year, you can see that there was only very small amount who had severe MR. The rest were all in mild to moderate. And even with reduction in your improvement in NYHA functional classification, whereas most were in NYHA 3, 4, now at 1 year, people are in NYHA 1 and 2, most of them. So which is very reassuring to see that over a period of 1 year, people have found COAPT-like results in the COAPT PAS, which is but more serious patients. And this was just concluding. And so there is a lot of evidence to show Mitraclip works, and there is a need for it. So I'll just show some nice images, as we interventional cardiologists only understand images. Who wants to look at the data? So there is an image and what you do. So you're going transeptal. We have a bicaval view, and we tent the septum with a needle, which is ordinary, as Kassasab just said, like a transeptal needle. And then we look at it in 2 other views, which is the short axis view, which helps us understand anterior and posterior. So we need to be posterior, we need to be superior, we have to be about 4, now 4.5 with the longer clip arms, and then we go transeptal. And we then go across the septum, and this is how it looks in 3D when you are across the septum. I can see Asad here, he has done some procedures, so he would be thinking about this now. And next is, once we have crossed the septum, we then take the clip, and as you can see, the clip is being positioned, here medial laterally, and here posteriorly, anterior posterior. So heading towards the mitral valve. Once you are there, you then cross the mitral valve, and this will show how we grasp. Then we slowly move the clip back, and we entrap the leaflets and drop the grippers once, and then close the clip. And that reduces the MR. And sometimes if you've not had good result, you can reposition the clip, you can reopen, you can put more than 1 clip. The maximum we have put is 7 or 8 clips with the, in Barlow's disease. And so this is how the clip works, that you've got the leaflets now resting on the clip, then you drop the grippers and they get entrapped, then you close the clip. So you have, what we call as a successful clip deployment. And this is how the valve looks before in 3D. Where you can see anterior posterior leaflet. And this is how the valve looks after clip. There are two clips there. You have two little holes, a medial and lateral hole, and the two clips. So this is how it looks after. And this is what an angiogram looks before clip. You can see MR into the left atrium. And after clip, one clip, there is no MR into the left atrium. And this is the most rewarding bit that I feel when I've done a procedure, that you see the left atrial pressure, which is in red, drop from 60-70 to just 15-20. And that really must translate into clinical improvement of the patient. So that's the most rewarding bit. And this is what we see at the end of the procedure. If you're not using a closing device, you will just see a figure of 8 stitch. So this is truly micro, as I call a small scar that you have in the groin. Now compare it to when we say robotic minimally invasive surgery. This is what it looks like. So you can see the difference, robotic minimally invasive surgery and minimally invasive Mitraclip. And this is the minimally invasive, which I really don't think is minimally invasive. Up till now, we have done 150,000 procedures worldwide. And I must show you this picture, which is the team that did the first Mitraclip in Europe. Nadir was there, but he ran out of the cath lab. He was there with me in that. Thank you very much. Thank you.